now it's actually a very great pleasure and honor to introduce the next key speaker, Professor Maurice van der Bosch. When I talked to him just before the event, I said, how do you want me to introduce you? He said very shortly. But it's very difficult because he is a professor of interventional radiology. He was one of the first in Holland who realized that collecting data is so important to improve healthcare. He's now a CEO of one of the largest teaching hospitals in Amsterdam, CEO of Centon, which is a hospital group which are very keen on value-based healthcare. And he's a strong believer in digital healthcare. And that's one of the topics he will discuss with us. And he has a marvelous title. I was jealous for the titles. Future has no walls. Maurice, please, the floor is yours.
Thank you very much for this introduction, kind introduction, Hendrik. And good afternoon, ladies and gentlemen. Fred, thank you very much for this invitation. It's a real honor and pleasure to be here and in this wonderful environment. For me, one of the first times in such a comfortable and convenient atmosphere in a conference, in a meeting with so many colleagues from abroad. So that's and also the nominees. It's a real honor to be here. Before I start with the keynote, which will indeed bring the perspective from a hospital point of view on the future that we have, not only as an organization, but more and more as a learning network, as a learning healthcare ecosystem surrounding patients and citizens. But before that, I would like to congratulate you, Fred, and your team with all the work the past 10 years. I mean, after Professor Michael Porter launched the concept of value-based healthcare and bringing, let's say, volume to value, you really shaped the implementation in Europe and especially also in our country with all kind of, let's say, days like this and nominees with innovations to drive it forward in practice. And I think that's a major achievement, so congratulations for that. The perspective from the hospital, I think there are a lot of, at least I had some nominees around the table, and they were also or working in hospitals or chairing hospitals, let's say healthcare organizations, because we are also here with tech companies. But we still almost now forgot that we had a major disruption, let's say more than 3 years ago, in 2020 when the COVID pandemic started. And we almost forgot it, but it really disrupted healthcare. And every time that I am in the hospital on a daily basis, talking to professionals, nurses, physicians, it's still the burden and the effort and the amount of work, and especially also the people, the patients that they took care for, is still in them and in the system. And we had, of course, this increased burden of costs, in which quality was our main focus to aim for. But now it is accessibility of care. And I think that everybody here in the room will agree that accessibility of care is our major challenge. And I think that that is due to the shortage of healthcare professionals that we have at the moment. And Fred mentioned it in the beginning, do you move from fear or from chances? But I think it's important to highlight that this is a research survey in 2020, which was in the first COVID year, but you have here 1 out of 4 ICU nurses reporting or high levels of anxiety or depression. So these are results in people in our system, in our companies, in the hospitals, taking care of patients, but they are under a huge amount of pressure. Why am I highlighting this? The main thing I think for the coming 10 years of value-based healthcare is not anymore the concept and the outcomes. The main challenge is to really get it implemented. And that means that we need to work with the people who have this daily day-to-day pressure on putting the right care for our patients. Of course, there are also opportunities, and one of the many nominees actually are highlighting that patients are becoming more and more smart consumers. We have more digitalization, we have more data. And it sounds quite obvious. I mean, we had an impressive story of one of the leading patients in the Boston area. But we are still very much a physician-oriented system. And I like to highlight that with one of the notes. This is Charles' daughter. I'm an interventional radiologist myself by training. Of course, I was not born then, but this is from my mentor when he was visiting actually this area in Utrecht. And he invented the balloon angioplasty, like you have all your innovations. And then he needed to convince surgeons to stop cutting off legs from patients and start putting in balloon catheters. You would say, looking at the value-based healthcare outcomes, they are quite, that's a good innovation, right? And it took 20 years to really make the shift in the field from open surgical procedures towards the PTAs. And here you have a short note from one of his befriended surgeons. Visualize, Charles, but do not try to fix my patient. And I always highlight this when I'm in an environment with colleagues and everybody's telling we are very patient-centered. I say, well, this is mainly how we are now. But we are also shifting rapidly, fortunately enough. This is an example from my hospital in Amsterdam. We now have remote monitoring, of course, in place for most of the chronic diseases, but we also have these famous Dutch bikes, and we can visit patients outside the hospital, not only our nurses, but the GPs or the long-term care nurses, and in this way we deliver now chemotherapy not anymore inside the hospital walls, but outside at the homes of our patients. Hundreds, thousands of patients in our area. I think this is an example that the patients become more and more empowered as a citizen and less a patient. And this is an example of the Santion group that the digitalization really did take off in 2 weeks. We had an immense pressure on our emergency departments, and we decided with 7 hospitals and later on with 14 hospitals to really start collaborating on monitoring patients on a large scale, 130,000 citizens per day. And here you see the real-time data that was in place in the medical service center that we had in Amsterdam. And why am I showing this? Because here you have real-time data and also the possibility to share these data with your colleagues. And I think if you look at the next level of value-based healthcare, it is if you have the ability to make the connection between the different data systems, you have the ability to scale up. And I think that's another challenge that we are facing, but it is doable. So this is an example that it is doable, and of course you will have examples for your own, but this was a nationwide coverage and was actually the first time in our country, so that is why I'm showing it. I think if we look at not anymore the importance of a hospital and professionals in relation to patients, but if you look at the healthcare ecosystem, even more than before, even more important than the past 10 years, will be our ability to prove our value based on the transparency of our results. And at least in the Netherlands, it's easier said than done, because we have at certain IPUs and in certain hospitals transparency of results, but mostly we are a closed system. It's very difficult to find for patients the best location for your pancreatic surgical procedure, for example. So the external transparency is still not there in place yet. And if we are operating as a healthcare ecosystem, you want to know from all the partners, how are they performing? So I think also next step value-based healthcare is not anymore in your specific institution alone, but the care pathway from home to hospital and back with all the partners involved. This is the quadruple aim. It was mentioned before, but of course the value-based healthcare started very much on population outcomes and reduction of costs. And I think now more and more we all know that especially the patient experiences, and we heard it from our colleague a few minutes back, that the patient reported outcomes measures and experience measures are becoming more and more important to individualize and not only to standardize how we measure outcome. I show you this because in Santion the past 10 years, it's no coincidence, Fred, but we also are now 10 years, we have a nationwide coverage of 7 hospitals. We have 15% of the whole hospital care in the Netherlands, and the raison d'être of these hospitals is value-based healthcare. And I will show you one example, but we have many different care pathways. But the key, I think, why we are still successful are our professionals and their willingness to share this data and willingness to improve. So I would like to also share a few examples of how we put it in practice. So it's not only theory, but it is skilled in this system of 7 hospitals. So we now have what we call Health Intelligence Platform Santion, which is a real-time platform who's putting all the data of the care pathways from the EMRs of the 7 hospitals towards one place. So that was a major achievement that allowed us to really look real-time at the data and collect the data and look for differences and the analyzing and identifying of improvements possibilities. I don't know if you have the same experience. It's very hard to find the data analytics, the data analysts that you want to have. And if you have a group of hospitals, it's more easy to attract the right analysis and bring them together and do the measurements as you want them to be done. The improvement cycles, they are run on a 6-monthly basis. That seems quite long, but the most important thing is that in the 3rd phase of implementing improvements, the teams are really working and discussing together what is needed to make these improvements. I will show you in a short second how it is done, for example, in breast cancer. At least that's what I hope. Next slide, please. Yes, yes. Thank you. So, the disease care pathway is defined, and the treatment options, of course, in case of breast cancer, is breast-conserving surgery, is amputation, it's chemotherapy, it's systemic therapy, hormonal therapy, it's immunotherapy, it's radiotherapy, and then we have these scorecards, not only on the clinical outcomes, also on the PROMs and the PREMs, and they are standardized. This is the ICHOM scorecard, most of you are familiar with it. And then we say, okay, this is how we want to measure in these 6 monthly intervals our outcomes and try to make our improvements. Then we have the multidisciplinary teams in place in these 7 hospitals. They work together. Here, for example, this is only the breast cancer IPU. Here you see the people who are involved. And it's not necessarily now to look at hospitals. I only show you this to show and to share how you can improve. So this is the number of positive margins after breast-conserving surgery, and you want to have them as low as possible. The thing is that the moment that you have a higher number of re-excisions than your colleagues, you can discuss with each other, and especially by learning from the group who has the lowest re-excision rate, what did you have in place to have this result. And what we found out was that in the hospital with the lowest number of re-excision rates, they use standardized ultrasound in the operation theater to look at the tumor margins, and that allowed the surgeon to cut more closely. More important, also there were differences in pathologists of looking at the margins. Was it a half a millimeter as a margin? Was it 1 millimeter as a margin? And you see that also not only on the surgical part, but also on the imaging part, on the pathology part, you can share your outcomes and your experiences, and then you can come to a standard way of work. We have quantitative and qualitative results, but the most important thing is then we have the results after internal validation, external, transparent, and we define the standard of care. And we bring them online for patients, with patients, but also for other hospitals to challenge us if they have better or other results. And I think that could be an example to move forward in the country. One of the key things now is that we are moving from a hospital more and more towards a healthcare ecosystem, a learning healthcare ecosystem. We want to have this seamless movement of citizens or patients from preventive care towards hospital care. And where do we bring what kind of value? It should be mentioned that in our country, which is a small country with around 70 million people, we have 90 hospitals. It's a very fragmented system. We have, depends how you count, but up to 20 insurance companies. And we have a lot of GPs. So we have regions and a lot of interests of groups involved in care. Whereas you see that if you look at the complexity and acuteness of care, concentration is needed. And for the lower complex care, decentralization is needed more and more towards the homes of patients. But it is difficult for us to make these choices, but you will see that patients, based on their outcomes and based on their digital technology, will request more and more that not hospitals, but ecosystem in regions will start to behave as one. And is that possible? Yes, that is possible. Well, first of all, why is that important? This is an example of our ER department. We have 70,000 patients per year. And we find out that after we merged our 4 locations into one, that the door-to-needle time for stroke dropped from 61 minutes to 18 minutes. And we know that that is brain time. So it is related to better recovery for patients. So I always mention concentration for complex and acute care is very important. And I know that people will think differently, but the outcomes show that concentration of complex care and acute care is very important. Why is this ecosystem so important? We had the shortage of staff. We know from reports, this is a report of Gupta, that around 50% at this moment what is delivered in hospitals would be delivered outside hospitals, and especially in a digital fashion. So I think the combination of proving your value more digitalized with real-time based data in a learning healthcare ecosystem is the way forward for the coming 5 years, and to prove this value in a region. And my final slide, this is how it could be organized. I will skip this one. If we would agree that that is an opportunity, why is it so difficult? So I think our advantage is that the patients become more and more smarter, and they have more and more access to data and their outcomes. The problem that we have is that our healthcare employees, they are short of staff, so they are very busy running the daily operation. And if you want to put change and put a new way of work, for example, shared decision making, and discussing the outcome with patients, it takes more time in general. It's a challenge for them, but we will manage if we become part of a larger healthcare ecosystem. The drivers for change will come from the outcomes that we will have in place, make transparent for patients. Patients can choose, have a clear role in the ecosystem more than everybody is doing the same. Digital health, by making also the accessibility to data available on a real-time value-based healthcare basis, will help us the coming years to do so. But therefore we need to build strong collaboration with insurance companies. I thought your example was a great example how when you collaborate with insurance companies, also the payment, not for service, but bundled or population health, will make another behavior in your company more accepted, because in the end you get what you are paid for, to be honest. And we will need to come up with new business models. Collaborate on the data science. We need smart people. We need smart people to look at the data, look every day at the data, come up with ways to improve our healthcare delivery model and prove our clinical value. And I think the last point that I wanted to make is, like you all sitting here, basically as leaders in the field. And we need to build, and this is why also your initiative is so important, Fred, you want to have a spread out like oil of this way of thinking, because it takes courage to do things differently. Like the ladder of Charles Dotter, it did take him 20 years, but in the end you will change the system. So also the disruptors from outside, I see some faces here, it's very important to change the field. I think this is what I would like to share with you. Thank you.
Thank you so much, Maurice. It's, as always, very inspiring. There might be some question from the audience, also online, if you have